Hello, I'm Dr. Shlomit Schaal, and I'm the Chief Physician Executive at Houston Methodist. Welcome to our show, Women in Surgery. We highlight here our very best physician surgeons at Houston Methodist. All of them just happen to be women. And today it's going to be a very exciting show, a little bit different because we have two guests, not one. The first one is Dr. Patrick Reardon. He is the Chief of Minimally Invasive Surgery at Houston Methodist Hospital. And the second surgeon is Dr. Connie Au. She is a surgical resident. Welcome to you both.
Thank you.
Let's start with the lady, Dr. Au. Welcome. Tell us a little bit about yourself.
I'm from California, born and raised. I went to UCLA for undergrad, UC Irvine for medical school, and I'm now a PGY3 here in Houston Methodist for surgical training.
Fantastic. And Dr. Reardon, tell us a little bit about yourself.
Dr. Pat Reardon, and I'm not a woman, but I am happy to be here and discuss what I think are important issues for women who travel this path.
Tell us a little bit what you do here.
I am the Chief of Minimally Invasive Surgery at Houston Methodist Hospital and head of the Division of Minimally Invasive Surgery. And my practice is almost entirely general surgery done in a minimally invasive fashion.
Fantastic. So Dr. Au, we have been interviewing surgeons here at the show. We never had a resident, woman resident.
Okay.
Tell us a little bit about you and your life as a resident, how difficult it is or easy.
The main thing was when starting surgical residency was adjusting to the 5 a.m. schedule where you wake up at 4 a.m., you get to the hospital at 5 a.m., you kind of see 15 to 20 patients a day on your own initially before rounding. It's a hectic life. You're forced to multitask. You're kind of forced to become efficient really quickly in the beginning. Nowadays, it's less floor work and more surgical training exposure. So it's nice in that sense. The residency lifestyles, in a way, better than what I anticipated when I first came here.
So how many residents do we have here at Houston Methodist, surgical residents?
So it's six per year, and 2 prelim positions right now. I think we have a total of 34 residents in our program.
And how many women?
I think we have at least more than half are female.
Fantastic.
Yeah.
So Dr. Reardon, this didn't used to be the case, right? Tell us a little bit about your residency training. When was that, and how was it different than it is today?
I did medical school, general surgery, and cardiothoracic training all with Dr. DeBakey, and it was exceedingly different. There was a single woman in my class, and she was the second one that I ever saw in our training program. One had graduated before I started. Dr. Mary Brandt wanted to do pediatric surgery, and so because of the relationship with Texas Children's, she was the only person who did not want to be a heart surgeon, and the only woman that was a general surgeon in the residency the whole time I was there. Very different world. It was a man's world.
So a man's world, what does it mean?
It meant that women still didn't receive equal treatment, equal respect. The things that would be said to them back then would get you fired in a heartbeat today. And so it was a much harder path than I had to travel. It wasn't easy. Working for Dr. DeBakey was very difficult, but was more difficult still if you were a woman in a world that at that time was entirely dominated by men.
Dr. Au, you said that we have here 50% of our residents are female. Is that special for Houston Methodist, or this is a trend nationally?
I believe it's a trend nationally. In fact, when I was starting medical school, I was told if you can think of any specialty other than surgery, you should choose something else. Mainly because it is a very difficult path. You're spending long hours in the hospital compared to other specialties, for instance. But we are seeing more and more females apply into surgery, and I think it's because we see more representation within our faculty, and as well as the numbers also prove that more females are applying and getting in.
So Dr. Reardon, you talked about the respect or lack of that used to be, I don't know how many decades ago, but you saw the transformation, how it changed. How did it change? What did it take to make that change?
Well, primarily I think it was a societal change. So the concept that any minorities would be treated differently in the 70s and 80s when I started, vastly different from the way it is now. And so it was, I think, society driven.
Society driven, however, the surgeons themselves, who were macho men like you.
We lagged behind, but it has been corrected. Connie said, maternity leave. I'm married to a physician, and she's a bright, hardworking woman who is devoted to her patients. And so when people would say, well, they're gonna, take time off for maternity leave, I don't have to do their work, or they'll get married and they'll quit, that would drive me nuts. It's always bothered me that people had that notion. If you do that, half of your possible good surgeons are off the table. It's crazy.
So you have seen that evolve, and the fact that you were married to a physician helped you. Have you seen how it evolved in national level in terms of, how many heads of departments are now women, departments of surgery? How many program directors are women? How many faculty members are women? In general, we don't want exact numbers, but have you seen that evolution?
It's changed immensely. When I was a resident, I believe we had one female faculty member. And when you went to national meetings like the American College of Surgeons, the number of female leaders in the surgery world back then was, you could count them on one hand. If you go to meetings now, women are represented almost equal to their percentage of the population, and they have very powerful positions within surgery, an idea that was absolutely unheard of during my formative years.
So, Dr. Au, has this really changed completely, or you feel that there are areas that we can do better? In terms of support, it is really, even today, when you say society has changed, we still have roles that, are still left to the woman in the family. I know that from my own experience. So any perspective on that from your point of view?
From my point of view, I think the surgical training definitely has become more accommodating. Maternity leave is now an option, as I mentioned previously. Paternity as well in Houston Methodist is also an option. They give, I think, our male colleagues at least 8 weeks at most for paternity leave. And I think that's a nice kind of equality factor, as well as the residency recognizing wellness and the need to kind of be at home for certain things like taking care of children. I do see some of my colleagues struggle with having children and having to do the weight-bearing kind of roles with that, such as, they are getting up at night to breastfeed. I think we have at least one resident in our cohort right now who has twins, and she's recently given birth. So hearing her struggles with, not being able to get sleep on top of working, I can imagine it'd be very difficult to do both things at once. So a lot of female surgical residents end up doing research years to try and, have families during that time period.
So Dr. Reardon, you are a mentor of both men and women, and I know you're a very passionate mentor of the next generation. How do you make sure that you train the next generation to be better than yourself?
Well, for me, I just try to pay it forward. I trained with, really blessed, when I was in training, a significant number of the world's very best surgeons were in the Houston Methodist Hospital. And it was a passion for excellence that Dr. DeBakey passed down to everybody. And so I try to do the same thing and pay it forward and try to encourage people to put the patient at the top of their list every day. And to do that, that means that you have to be the best that you can be as a surgeon. And so with our residents, if I have any message for them, that's it. That's the reason we exist, to provide good care. And so I try to be passionate and pass it on to them.
And you have female trainees and male trainees. Any difference that you see? Even physical differences in what you can and cannot do?
I would say no. So we have a fellowship that's, I have my fellows 57 and 58 that I've trained are in the program now. And so out of that total, 21 have been women. And we've had, there's a contest they do every year to train in laparoscopic skills. And we won the first 5. And so on the 6th one, we were at the American College of Surgeons, and another faculty was standing next to me from a different institution. He didn't know who I was. And I heard him tell his colleague, well, we're finally going to win one this year because Methodist sent a girl.
Oh my God,
So
that's
I went over
okay.
and
I hope they lost.
Well, I told my fellow what they said, and she got very excited, not happy. And I said, no. Be very demure, act as much like they would expect you to act as you can until the competition starts. And she thrashed everybody so badly, she could have quit the whole last event, and they never could catch her. And so after that, we went out and I took her to dinner and we celebrated because she absolutely embarrassed all the males.
So that's interesting. You're specializing in minimally invasive surgery, which means laparoscopic technique. And in laparoscopic techniques, perhaps, there is no gender difference because you don't need, physical force, right?
That's
or you don't
correct.
need to be tall, you don't need to be strong.
No, so if you're doing certain specialties, orthopedics, that's one classically where people would think of not just males, but sort of big burly males. And I don't know if you've ever tried to set a bone, but it is not easy work. And so there is some advantage to physical strength, but in minimally invasive surgery, we're operating with very fine instruments through trocars. There's no advantage to being big and burly, it's just having good skills.
Fantastic. So you're growing up in a new generation, in a new environment. Tell us about your mentors. Who are your mentors, both men and women? How are they different?
I mean, I would say Dr. Reardon is definitely one of my mentors. Dr. Martinez, who's our program director, Dr. Tapia, they're female surgeons who are in our ACS program, and they're great surgeons. Dr. Martinez is definitely, I think she's the head of the ACS department, and so she has a lot of, not stance, I don't know how to say this, influence, within the surgical faculty, and so it's kind of nice to be able to hear her kind of advocate for us.
And you guys, tell us a little bit about your relationship. Mentor-mentee, how did you start? Maybe you went to surgery because of Dr. Reardon, is that correct?
I started before, I became a resident before I met him. I think I rotated on your service in March of my intern year, and he offered to send me to a women's surgery conference, I think around that time, but fortunately I was not able to go. So it wasn't until the second year that he offered the same thing again, which was very kind to be able to offer the same thing.
So what is a Women in Surgery conference?
It's a national conference it was held in Tampa this past year. It's run by Dr. Sharona Ross, and she invites female surgeons from all over the world to come and talk in a panel. And they have various topics such as global surgery, advocating for yourself, how to balance finances, how to balance family and work requirements, and it was a very great talk and very comprehensive in all those subjects.
So one of the things that we talked about when we try as an institution to support women is not only giving women opportunities, but also investing in people like yourself, allies. So how could you be of help specifically for women? What is your role as an ally?
Well, what I can't do, because I'm a middle-aged Caucasian male, and the path I traveled, I was surrounded by Caucasian males, and so I can't help them with the struggles which are unique to being a woman in the world of surgery. And so one of the reasons that I wanted Connie to go down to the Women in Surgery meeting is these are not just women in surgery. These are the movers and shakers of the current world of surgery. And so I don't think that Connie needs anything other than an equal opportunity. And that's really the way I see it, right? Women don't need an advantage, but what they do need is a fair and equal opportunity. And I told her, I'm giving you an opportunity. What you make of that opportunity is up to you. But these women, to get to know them and network with them, your future in surgery can be very strongly and positively influenced by having met these people and have them understand that you too are a good surgeon. Surgeons, when you're young and you're just getting started, there's a lot of internal fears that, am I good? How do I compare to my peers? And it's nice to have somebody that looks like you and has traveled the same path as you to say, that's how we all start out. You're doing a great job, and maternity leave, you're going to make it through that, and you'll still be a good surgeon when you come back. And so for me, I can't help them with that, but I do have colleagues who are respected, well-known surgeons, and so I try to make sure that I can get people like Connie, who are good surgeons, to get down and talk to somebody who can relate where I can't, and who can give them a leg up if they want to pursue a career in surgery.
Yeah, so well said. I think, giving this, I think you told me a story outside of the show when we were talking about other things. You told me how Dr. DeBakey told you that you're good, and you remember this until today, and it gave you confidence to continue and to be what you are today. So I think even though you haven't traveled in the same path that women do, if you tell Connie you're a great surgeon, she would never forget that.
Well, and it changed my career, totally changed it. And so I can, and I did tell Connie, you're good, that's why you get to go. I have limited resources, and so I do try to focus them on the women I think have the greatest potential, so that my resources can do the most good.
Fantastic. I want to ask you about patients. So changing, the mindset of surgeons and your colleagues is one thing.
Yeah.
But how do patients react? Do patients treat you? I mean, obviously you look very young, and you're a woman, and still, it's 2024, but still, we are in a world where people, maybe older patients that you take care of, how do they respond when you come as the surgeon?
Sometimes they do ask, are you the one operating on me, or when am I going to see the doctor? I often get mistaken for a nurse, and that's just not just by patients, by other nurses and other staff. I think it's mainly because I am a female, I'm not wearing my white coat. There are certain female attendings who do round with their white coat intentionally in order to make sure they're recognized as the surgeon and the person operating on them. So there are certain things that we can do to make sure that they are aware. I always introduce myself as Dr. Au to all my patients when I see them. There are certain patients who you do have to be more gruff with, where you do have to kind of have a harder stance with them. I think when I was on ACS this past month, we did have a couple patients where we had to say, do they just want a man to tell them the plan?
Interesting.
I feel like they.
And so what do you do? Do you ask somebody to help you with that? I mean, how is that handled in the everyday life? Because it is a problem. We can't just ignore it. And the number one thing between a doctor and patient is trust. Mm-hmm. And sometimes trust is not what you say, it's just how you look. Yeah. And how you look is a perception, right, for a patient and a surgeon. So what do you do to kind of bridge that gap of trust?
I usually just say, I'm in this year of training. I am the person providing for you. If this is not something you would like, I can be more than happy to provide you a different provider. But I'm fully qualified to be able to handle the situation. If you have any questions, you're free to ask. And if there's anything that I can do to accommodate to your needs, I'd be more than happy to do so. And so I ask them, kind of what their problem is, and try and see if it's a gap in knowledge. Or if it's just an inherent distrust. And unfortunately, sometimes you can't fix that. And if it ends up being where I have to ask a male colleague to go speak to a person, then they're usually happy to do so. Yeah, and I'll go to the room with them. I think that usually helps too, for them to validate that I'm also there as a colleague.
So you go into the room with your male colleague. Yeah. Interesting. Did you have to do that with any of your trainees? Go into the room and just kind of validate what they're saying?
But in 41 years as a surgeon, I never got asked, are you the nurse? And it's disturbing to me that all these years later, if you walk in and you're a woman, the question is, you must be my nurse because you're a woman. That's a little bothersome. That never happened to me. So
that's interesting. No, it happened to me for sure. Yeah. And the interesting thing is that, at the beginning when you're very young, they really think that you're the nurse. But then as you get older and your tone gets a little bit more confident, that actually passes, And
I like to think that I go in with a stance. And maybe it's the way I'm walking in that I want to portray that I am the doctor. But most patients don't have that issue where they call me the nurse. And if that is the case, I quickly correct them.
I'm just curious if there are studies, there must be, but I'm not a surgeon and I don't know. But is there a study of, I know in quality there are studies comparing results of women and male surgeons, and we can talk about it a little bit, but are they're in your field kind of comparing according to the gender of the surgeon?
There was a study, I think last year, on laparoscopic cholecystectomy from Europe, and the women overall had better outcomes in the male cohort, which of course on my side of the fence led to much grousing and, there has to be this reason or that reason. They got the easy cases, etc. But that was the data.
Yes, interesting. It's also the same in the quality field. You see higher quality in female physicians, and then they're saying, it's not really the gender, it's the amount of time you spend, and really touching to what you said, that you kind of try to prove yourself, so you're very careful not to make mistakes, and perhaps you're less confident, and if you're less confident, then you are really meticulous and following step by step. What makes a great surgeon?
Well, I was trained in the house that Dr. DeBakey built, so foremost in my mind is skill. So I just posted something about this. Two physicians, a surgeon and a medical doctor, can both have very high levels of cognitive skill. So they examine the patient and they put all the test results into their head and they compute it and they come up with the right diagnosis. And then they've also got a really good cognitive skill set on the current therapy and they know the current best therapy. But if you're a medical physician at that point, you write a prescription. If you're a surgeon, you pick up a knife. And so that was the way that I learned it, was now the rubber meets the road, and it is a visual motor sport. And so I really think that the best surgeons, they can't just have the best hands. You have to have the cognitive knowledge to go behind it. But all things being equal, with Dr. DeBakey, I wanted to have good hands.
Interesting. Do you feel that a good surgeon today maybe is different than those just the skills? Does it take something else?
I mean, I'm in a surgical training, so obviously my view of what makes a good resident is a little different from what makes a good attending surgeon.
So what is it?
So from a residency standpoint, what makes a good resident surgeon is really just being a team player. How reliable are you? Are you dedicated? Do you have a good work ethic? Are you dependable? All of those are factors I would want to see in a surgical
I agree with all.
surgeon.
Yes.
From a attending standpoint, it's obviously skills. You want to make sure you have the knowledge base. You want to make sure you have this operative skills to back up everything that you're doing as well. You want to make sure you have minimal mistakes, accuracy, and all of that. I think that is important, as well as knowing who to operate on. Medical or judgment in terms of surgical who to operate on is also something that we learn from our attendings, and knowing is this indicated, is this not indicated, knowing the oncologic staging and knowing all the background related to that. That's all medical, and that's not necessarily related to the surgical skills aspect. So that, I think, is something that I, as a resident, really appreciate from our faculty when they have a very well-rounded kind of skill set.
So when you come to the operating, I'm a surgeon too, so when you come to the operating room, you're the boss.
Yeah.
And for a resident, maybe that's not as scary because there's always an attending there with you. You're not alone. Have you seen, your female trainees behave differently than the male trainees in terms of you come and you need to be the boss and everybody needs to listen to you?
The only time, I don't think that it's a mental issue, but if any of my trainees have sort of a quiet voice, there's music playing in my OR. And sometimes they're bothered because they asked a scrub tech for an instrument, they didn't get it. And I always tell them, speak up. As you just said, you're the captain of the ship. And if you're talking so quietly that we can't hear you over the conversations in the room or whatever background music there might be, it doesn't really project the image of I'm the captain of the ship. So I have to tell them, let's project a little bit.
Let's talk a little bit about subspecialties. You see your female colleagues graduating and then going to subspecialties.
Yes, ma'am.
What is the number one for females? The most desired subspecialty?
I think right now it's trauma.
Trauma. Why is that?
I've been seeing a lot our colleagues go into trauma, especially what could we do trauma at Memorial Hermann, at least half of the faculty is female. That's not the case in any of the other surgical subspecialties we see here.
But why do they go to trauma?
I think it's a nice schedule. It's 2 weeks on, 2 weeks off. You don't necessarily have to be in the hospital at every point. The on-call schedule is also very nice and accommodating. I think that's the drawing factor.
And where's the least?
Yeah.
Where is the least? Where do we see least female? Which subspecialty?
I think it's CT surgery.
CT surgery.
Cardiothoracic.
More than orthopedic.
Orthopedic surgery, I guess I don't include that because it is not necessarily part of general surgery, but orthopedic surgery as well. I think that's mainly it. I mean,
How about transplant? We're very big at transplant here.
we have great female surgeons in our transplant department. Actually, we have Dr. Mobley, Dr. Chia, Dr. Simon, Dr. Yi. So we have great female representation in our transplant department. But CT surgery, I don't think we have a lot of CT surgeons, but none of them are female.
What excites you as a resident? I mean, you now see everybody. You kind of rotate around the different services. What is the most exciting for you?
Same minimally invasive surgery.
Well, I think it's great that we were able to work with these like world-renowned surgeons. I think in Houston Methodist, it's what's nice about our residency program is we not only get to work here, we also get to work in UT in the trauma side. And we get to work at MD Anderson. So we have a very good comprehensive program where we're working with the best of the best. So that was very exciting, is very exciting for a resident here. Right now, I am currently on my plastics rotation. I'm excited to be on my vascular rotation. And, we get to work with our Dr. Peden, Dr. Bavari, Dr. Lumsden. So that's something I'm looking forward to and what's exciting me at this time.
So really to work with people that are world-renowned surgeons, that's interesting. Dr. Reardon, talk to me a little bit about this evolution of robotics in surgery. You were trained in an era that, there was no robots, and now it seems to me as every graduate, like Dr. Au here, needs a robot to operate. I mean...
Well, we hope that's not true.
Okay, tell us a little bit more.
So, I trained with the people who had learned to make the biggest possible operations and have patients survive. Massive thoracoabdominal incisions, we would replace your aorta from your heart to your toes. Big operations. And so in 1990, in December, in room 5, where I operate every day, I saw the first laparoscopic cholecystectomy. And a lot of my mentors had never seen one, but they knew that this was some sort of scam.
So this is removing the gallbladder through small holes.
Small little incisions. They knew it would be dangerous because we had never seen modern laparoscopy. When I was a resident, we had laparoscopy. You put the scope to your eyeball. So you had one hand, you had to hold the scope, which means you could only use one hand, so you couldn't operate, you could just poke and prod. And walked in the room, they had a camera under the laparoscope, so now everybody can see, you can use both your hands. And so it totally changed the world of surgery, but it's a different skill set than just using your hands. And so it does require, I think, more practice, because every day we get up, we use our hands all day, every day, but we don't use them on the end of long sticks through hollow tubes. And so what the robot has done is make it a little more natural. It shortens the learning curve. And I think that probably all our residents would tell you now with duty hour restrictions, they got less hours in the hospital, less exposure in the OR. And so spend that much time having to practice, when you get done, maybe you're not happy, you don't think you have the skill set. So if the robot shortens the learning curve, then it does mean that hopefully they'll be able to still provide minimally invasive surgery, but at a higher level than they would if they had to keep working at it otherwise.
But isn't it true that once you're trained with a robot, you continue operating with a robot as an attending?
Well, that's true of everything we do. We get a lot of support from industry, and they do want to help create the next generation of good surgeons, but they also know that humans being humans, once you train with something, we're very reticent to change.
Yeah.
So people that learn on the robot are unlikely to make the time and effort to go back and acquire a new skill set. And that's just human behavior. We have Mighty, as you know, it's an institution where we want to train graduated surgeons as new things come along. And because surgeons tend to get out from their training and they get a little stagnant. They don't learn new skills unless they're economically forced to. And so you're correct. If you learn on the robot, you're unlikely to try to learn anything else unless the economics of the world force you to acquire other skills.
But from the big, long, complex surgeries that you did in your training to the robotic surgery that you're now doing in your training, really the big jump in quality was from open to laparoscopic, right? That was less complications, less day in the hospital. I don't know if quicker surgeries, probably at the beginning, not quicker, but really it improved the results. Did the robot provide the same kind of improvement of surgical results in comparison to just minimally invasive?
No, it's a subset of minimally invasive surgery. What it did do was make a lot more surgeons have access to be able to perform those operations because they felt uncomfortable, they had inadequate skills with regular laparoscopy, so they didn't enter the marketplace, which meant that patients were getting open surgery because their surgeons couldn't do it laparoscopically. So what the robot did was bring a lot more surgeons into the marketplace so they could provide minimally invasive care, and then you see the lengths of stay come down, the complication rate go down because they're not getting open surgery.
And tell me a little bit about surgery, treatment with surgery, while treatment with medications. We hear about new and exciting medications. Can these replace surgery? What do you think?
It's an ongoing topic, I think, that bariatric surgeons are kind of in the middle of discussing. I think some of them are even adopting medical practice, like a medical practice where they're prescribing obesity drugs. And it is a concern that, you're not going to have enough patients to operate on with all these miracle drugs out in the market. So it's an ongoing debate. We'll see what happens in the next couple of years because obviously drugs are going to fail. You're definitely still going to have patients who will require surgery at some point, but the number of people you operate on may diminish.
So you think that the future is in kind of big centers where you do a lot of surgery, and then maybe, other surgeons are going to treat the community in just smaller centers, maybe prescribing more medications? Or will we need surgeons and a growing number of surgeons, as the population grows?
So it depends on the specialty. Connie talked about being excited about trauma. Trauma's not going away. Bariatric surgery, it's made a measurable impact on all of our surgeons in our system who do bariatric surgery. And so starting about 3 or 4 years ago, when my fellows would come in and say they want to be bariatric surgeons, I would tell them, no, you want to have bariatric surgery skills because I believe in their career, the operation will go the way of things like vertical mending gastroplasties, which were done when I was a resident. And now we hardly ever see them. All the people who had them, we've fixed the ones who had trouble, and there's no more new ones. And so it's hard for me to imagine, but Connie may hit a point in her career where they go, look, this person had a gastric bypass for weight loss, come look, because no one does them anymore.
Wow, so you see these kind of surgeries that are actually long gone, people don't do them anymore. And I think that's actually one of the most exciting things about surgery as a specialty in general, is that you have new technique, and I don't know, every decade or so, you have something that changes the market completely. And in this case, it's medication, but it's also techniques, right? There's surgical techniques that somebody invented. Maybe you were part of the invention of several surgical techniques. And once you do that and people adopt that, people forget about the old ways of doing things.
Well, I'm happy I'm at the end of my career because as medicine has progressed, there are a lot of things that we used to just say, well, that has to have an operation. Turns out it doesn't as we learn more and more. Like I say, the good news for Connie is that until we can fix genetics, hernias, they'll keep coming.
Yeah.
Big people will keep coming, but unfortunately, they may not require surgeries. They probably get cured with
But hernia surgery also evolved, right? It's also changed.
Well, so we do it in a less invasive fashion, but the good news is that Connie if she's a general surgeon, she'll still be able to put her kid through school doing hernias and gallbladders because we don't know how to make those stop.
So tell me, Connie, what is something that you are afraid of or just makes you scared as a resident?
As a resident? Oh, man.
Don't say me, please.
I think Honestly, there's not much. One of the benefits of choosing surgery is I know that no one's going to take my job away. You know, radiology, you have the threat of AI. Emergent ED, you have the threat of NPs and PAs kind of coming and taking over. But with a surgery, that was one of the benefits of choosing surgery is I'm not worried someone's going to take my job. I'm not worried that, I'm going to not have patients to operate on. I think that's something that I'm not afraid of.
So you don't have kids yet. You have kids.
I have 4 of them.
Did anyone follow you to medicine?
So the lifestyle that I lived, not just as a resident, but when I first got out, I missed countless plays and sporting events because my mentors all said, your number one job is to the patient. And so my children looked at that and they have told me, we understand that physicians, that you help people and you're sacrificing your time for other people, but we don't want to do that in our lives. We would like to spend more time. So for me, I now have grandchildren, and so I'm making up for it. I spend as much time as I can with my grandchildren because, I missed a lot of my kids growing up because I sort of had the DeBakey mentality that I walked out of birthday parties and events because the pager went off. They said, someone needs you, and away I went.
And it's still like that today. I mean, with all the protections and times or hours for your residents, once you stop being a resident, your first obligation is the patient and their family. Does that scare you at all?
No. In fact, I went in with that kind of old school mentality. I always appreciated the fact that doctors provide so much sacrifice of their life for patients, and that's something that I wanted to do and what I intended when I initially signed up for surgery. It was something I was well aware of and something I was more than willing to do.
So something that medical students always ask me, and maybe you can answer, how do you know that you're going to be a good surgeon? I mean, we don't do surgery, to your point, we don't practice it, we do things with our hands, but how did you know that you're going to be good?
I didn't. I play video games. I mean, I'm hoping that provided some benefit, but really the main thing I think that really Dr. Reardon kind of saw in me was that I was a hard worker. I was willing to put in the time, adapt to his ways, kind of pick up on the nuances a little faster than others maybe. I think that was probably the only thing that I had going in, like a bit of an intuition for surgery.
Connie, it's an autocorrector, right? We want people who, once you tell them that something is an error or not the best way to do it, that's it, doesn't happen again, right? And then what happens is the bumpers keep getting closer and closer till you hit perfection. People who make the same mistake over and over again, Dr. DeBakey had no tolerance for that, and I must admit that he ingrained that in me. I don't do well if we have to tell you over and over again, don't do that.
So you have to be able to accept criticism, and that perhaps some people are not comfortable with, and then also not only accept criticism, but really change the way you do things to make it better.
Right. Adaptability is a key asset in surgical training, and something we look for in every person we apply and interview.
So do you feel supported, not only by Dr. Reardon, but the entire family, the entire faculty?
So I'm left-handed.
Oh,
actually,
tell us a little bit about that.
There's only 10% of left-handers are only 10% of the population. So
yes,
you can imagine.
I have 2 kids that are left-handed, so I beat the.
I was told when I first started that I have to be right-handed because it'd be really hard for people to teach you how otherwvascular
Interesting.
And so
it's really hard at open surgery because we don't know.
Yeah, they don't know how to do things like a vascular anastomosis left-handed. And so I actually had to kind of start becoming ambidextrous. I had a faculty tell me to start using chopsticks on my right hand. And so I had to accommodate and adapt. And I feel like I'm pretty ambidextrous now, but it is something that I think support-wise, they'll try their best, but at least with that aspect of surgical training, it still has to be improved.
And with the robot, does it make it easier for left-handed people to operate the robot?
Yeah.
Laparoscopy and robotic, because when you work with the laparoscope, your hands are propped over fulcrums. And so I'm not left-handed. In open, I don't know what my left-handed skills are, but I can operate left-handed laparoscopically because you have the support of a fulcrum as you operate. And I think that I can tell her how to operate laparoscopically left-handed because the view is the same. Open, it's really, really different because you have to perceive the world open in an entirely different way because everybody sees the same TV screen, but when we're looking down in the hole, it doesn't look the same. And if you're standing over there and I'm trying to teach you how to do it backward,
it's
hard.
difficult.
Yeah.
Wow.
And what was nice about starting off and being told to do things right-handed is we all start laparoscopic and robotic training at the same time. So I didn't feel like I was behind compared to others when that started.
Dr. Au, you came from a medical school to a residency program. Medical school is now majority women. It's also a very protected, sheltered environment. And then you're now a resident. You have to take care of patients. You have responsibilities. You told us how you get up, 5 o'clock in the morning, 4 o'clock in the morning. You have your patients. You have attendings that criticize you, want you to get better. How has that transition been for you?
Honestly, I loved medical school, but I was ready to be done with medical school. You're not part of a team when you're a medical student. And as I mentioned previously, I was told if I can choose anything else, then I should choose something. If I was interested in anything other than surgery, I should choose something else. Mainly because the female surgeons that I worked with when I was a medical student, they kind of disclosed to me their struggles with, work-life balance and like how to have families and whatnot. So I was told going in as a female, if I can choose something else, I should. Nowadays, I don't see that as being a major issue. Maybe it's because we do have great support here at Houston Methodist. And I feel like people are very accommodating to different schedules. People can make it to their doctor's appointments, and our colleagues are more than happy to take on the extra load. So I think it's a difference in culture between my medical school and here. Not to say that my medical school wasn't supportive, but it is a difference that I've noticed. And so I'm more than happy to be in the residency that I'm at right now. And as a female, I feel like I don't have any major issues compared to my male colleagues. I don't feel like I have a lack of support. I don't feel discriminated against or anything.
And for you, from the mentor side of things or the attending, you've seen many residents. How do you feel that attendings can be most supportive, specifically men supporting female residents? What can you guys do better, or what are you doing in practice to just support them through their residency program and make them excellent surgeons?
So I can't help them with the issues that come from being female. It's a different path. I do my best to smooth the path and get rid of some of the curves in the road, but I don't have personal advice about what to do when you're going to have a baby and be off and et cetera. What I can do is try to steer them down a path to excellence, and that it's not just technical excellence, like we talk, focus on the details, know everything about your patient, study so that you do have the cognitive knowledge base to come up to the right decision about what should be done. And then truthfully, no one ever says, go work with Dr. Reardon, he's going to teach you how to do NIH research. People come to me to learn skills. Because with Dr. DeBakey, he never once said, Pat, I'd like you to write an article. What he did expect was for me to display the highest level of skills and devotion and dedication to the patients.
And this is what you see in Dr. Au?
Well, exactly. In the OR, like I said, she was an autocorrector. Seriously, Dr. DeBakey, you got one. Once he actually have a quote of him saying he couldn't understand how someone smart enough, good high school grades, you get into a good college grades, you got into good med school. Good in med school, he wouldn't have hired you in his residency. So how could it be then if he tells you don't do something that's wrong, that it would ever happen again? And so I do look for people like Connie who are autocorrectors. They hear it, that can be done better, that was wrong, we're done with that.
So Dr. Au, you have a wonderful example of a mentor right here in Dr. Reardon. How are you going to be the mentor of the future generation? What are you planning to do? Or is it too early to ask you?
I mean, for now, I think having my interns know that there are certain microaggressions that they're going to deal with on a daily basis. You mentioned previously how certain male patients will not be able to recognize you as a doctor. They'll see you as a nurse first. You may get, they may second guess your medical knowledge just because you are a female, your technical skills because you are a female. You deal with that on a daily basis, and there are certain fights you have to fight and things you have to stand up for yourself for, and there are certain things that you do have to kind of just brush off. So kind of telling them my experience with that, I think, would be one way for me to mentor them. I have been talking to, our 4th year and 3rd year medical students and telling them, how to apply for med school. So I think I have a good experience in that sense, but from a female perspective, encouraging them to be leaders, encouraging them to be outspoken regarding anything that they think is not right. I think that's one way for females to have more of a standing within the surgical community, because we are perceived as meek oftentimes, and you do have to portray yourself as confident. And I think that's one way we can change.
Recently, I read the AAMC data about sexual harassment, and I saw that the surgical specialties, there's much more incidence of sexual harassment of surgeons who are in training, female surgeons, in residencies that are surgical rather than medical. So have you encountered that? Do people talk about that? And what are we doing today to mitigate that environment that can be, a deterrent for female surgeons?
Yeah, I think, I don't think I've experienced it, or if I have, maybe I was a little ignorant of their comments. There are certain phrases that, some attendings may say that they don't say to other my male colleagues, such as, you look great today. They'll talk about your appearance. And I think the appearance aspect is probably the only thing I could think of in terms of not necessarily sexual harassment, but just in terms of a difference between male and females. Thankfully, I haven't experienced any of the sexual harassment aspect, but I can see how certain things that people think they used to be able to get away with are no longer okay, especially with now cameras in the operating room and whatnot. So I think that is probably the only difference I've seen, and I've been very lucky that I haven't experienced it, or if it hasn't been any major infarctions.
Any thoughts?
So I grew up in an environment where the operating room was like the male locker room, and people would tell stories and jokes that clearly today would be considered absolutely inappropriate. It's not just ever, but particularly Houston Methodist, in our department before we had Dr. Barbara Bass, we had a woman chair. And so I think that it was made very clear early on that we'll have equal treatment for all parties, and that we're going to stay inside the bumpers. And so honestly, because I do have male colleagues in my age group, I don't think that the behavior exhibited when I was in training that I've seen it exhibited here at Houston Methodist, because based on the hospital's belief systems and having had a woman chairman who started our department, that kind of behavior was not tolerated.
I thought of something.
Yes.
There is one male surgeon who has used a female derogatory word when describing doing a procedure. And it was noted, and it was brought up with the faculty, and it was quickly shut down. So I think it's more of lack of insight, and I think for male surgeons, they just don't recognize what is sensitive and what isn't sensitive. And so as long as it's brought up in terms of someone brings it up to their attention, then I think behavior can be changed. And I think they should be responsive to feedback in that sense, and creating a very non-hostile environment for residents.
And you lived through changing the community of surgeons, so from being all males, now it's almost half and half. Is that better? Worse?
Well, I've told you that I'm married to a woman who's smarter than me, and that if you don't give women equal opportunities, half your good workforce is not on the table. I think it's hard to live in the South, though, because one of my strongest mentors was a guy named Paul Jordan, but in the South, saying sweetie or hun, people drop those verbiages. Yeah. That's just the way it is. Only now I have to remember, you cannot say sweetie or hun to anybody, regardless of their gender, because someone may be offended by it. It's hard for me. I grew up in the South. I still say yes, ma'am. Believe it or not, I've had people offended because I called them yes, ma'am, right? They think that that's sort of a, a master-servant relationship. So these are different times.
Yes. Well, thank you both for being our guest today. I learned a lot from both of you, and it's wonderful to have you both here, two generations, and really I think the future of surgery is bright. Wouldn't you agree, Dr. Reardon?
I agree entirely.
Thank you.
And thank you for watching. I hope you enjoyed this wonderful conversation with two very bright surgeons. See you next time.